JotPsych is a smarter way to run your therapy practice. A scribe assistant that automates scheduling, intake coordination, progress notes, and more. Try it free and get 50% off your first 2 months with code MODERN. Streamline your practice at jotpsych.com/modern therapist. That's JOT psych.com/modern therapist.
Looking for expert speakers for your next event? Curt and Katie, that's me, deliver engaging workshops on clinical, legal, ethical, and business topics. Give your audience practical tools to thrive as modern therapists. Learn more at therapyreimagined.com.
You're listening to the Modern Therapist Survival Guide, where therapists live, breathe, and practice as human beings. To support you as a whole person and a therapist, here are your hosts, Curt and Katie Vernoy.
Welcome back, Modern Therapists. This is the Modern Therapist Survival Guide. I'm Curt with Katie Vernoy, and this is the podcast for therapists about the things that go on in our world, the things that happen with us, the things that happens with our clients. And Katie and I, we like to explore a lot of the ways that intersectionality happens with many of the things that happen with our clients. And I will remind everyone that Katie and I are incredibly cis-het white people who don't have a lot of lived experience of some of the topics that we bring up. And that's when we invite our friends and people who know much more about these things than us. And really diving in today to the crossover, the intersectionality between marginalized and oppressed individuals, and specifically where it comes with facing infertility and infant loss. And we are joined today by Dr. Loree Johnson, LMFT, to help us with this conversation. So thank you very much for joining us.
Thank you for having me. I'm really honored to be here today.
We're excited for this conversation. Yeah, it hit home just as a throwback. We do have a couple of episodes on both pregnancy as well as infertility and child loss. And so this is actually deepening our conversation. So we're really excited to continue that conversation from before. We'll include the links to the other episodes in our show notes over at mtsgpodcast.com. But before I get started, I wanted to ask the question that we ask all of our guests, which is, who are you and what are you putting out into the world?
Well, my name is Dr. Loree Johnson, as Curt said, and I am a practicing marriage and family therapist in California. And I specialize in reproductive mental health, particularly in the areas of infertility trauma, and pregnancy loss. And what I put out into the world is deeply informed by my lived experience. I am a mom of one living child. I am also a bereaved parent. I've experienced 4 pregnancy losses over the course of an 8-year journey, reproductive journey, one of which was a termination for medical reasons. So I went through a very arduous trajectory to have my son. And I always told myself once I got to the other side of my grief that I wanted to give back. And so here I am today, really honored to hold space for individuals along their reproductive journeys, and also to support my colleagues in having some difficult conversations around, helping clients that look like me. And for people who can't see me, I'm also very cis and het at the same time, but I identify as Black, and that identity and that experience has definitely altered how I approached and navigated my reproductive journey. So I'm here to share that knowledge.
A lot of times when we start episodes, we start with a question around what a therapist normally get wrong with the topic at hand in whatever episode. We do it from a place of learning. Other people have made mistakes. Well, let's help other people not make those same mistakes. It's not a shaming question. But a lot of times, especially when we have kind of these intersectionality episodes, what becomes very evident at the beginning is how even a lot of the models that therapy is based upon don't necessarily meet all of the needs when it comes to some of the intersectional things that come. So all of that background comes to the question, what do therapists normally get wrong when it comes to marginalized and oppressed individuals who are facing infertility and infant loss?
Well, first of all, we don't get a lot of support with having difficult conversations or these conversations around intersectionality that lead us to feeling comfortable. And we know that just even the term kind of marginalized and oppressed is such a diverse term, and it doesn't always kind of account for the fact that there's racial diversity, ethnic diversity, sexual identity diversity, or gender diversity, that I think that as much as we think about context, we still might not feel as comfortable with exploring the context around these individuals as it impacts how we navigate holding space for them emotionally, or how our clients are accessing or attempting to access help emotionally or for their reproductive health.
I think a lot of assumptions can be made around what someone's experience is. And I know we have a lot of episodes around working with folks who are different than you. And so we'll link to those in the show notes as well. But I wanted to speak to your expertise in some of the factors that you've seen come up with the clients that you hold space for. Let's talk about health disparities and lack of access.
Yes. So it's hard not to talk about that without honoring that, there's so many systemic and structural issues and discrimination and racism that is at play, because it deeply impacts individuals' ability to access care. There's a perpetuation of stigma that occurs that exacerbates these emotional and physical challenges in some pretty significant ways. And we don't like to talk about the fact that healthcare, unfortunately, is tied to social justice and also, senses of opportunity and quality of life. So when we think about just access to care and being able to talk to an individual about what's going on for you reproductively, that's a privilege. And it's not always, it should be a right, but it's a privilege. And particularly Black and marginalized groups in the LGBTQ community as well, there's just this limited access because due to sometimes it's geography. When you start to deal with the fertility world, being able to, if you look at even the maps of where some of these offices are located, they're not even always located in areas that are serving the people that need to be seen. There are financial barriers, and these services aren't always covered by insurance, even though I know there's a lot of advocacy efforts that are happening to make sure that insurance is covering this. But also there's a piece around bias and, thinking or being mindful of when you go to seek help, will you see somebody who sees you for the whole person, who sees you for not just how you appear, but really appreciating the context behind that. So, and I understand that just my experience as a Black woman in navigating, the fertility world and also the loss world where, I kind of went into this very naively and didn't realize, going in that, even though we all might experience loss and struggles with infertility, we don't always experience, the groups don't always experience them equally. And so, there's this appreciation for some of the messages that clients are walking around with that they've internalized about their experience, about their fertility experience or their loss experience, that really colors their ability to seek care. So, and then that leads into another kind of disparity because there's the piece around bias, and the providers that you're seeking out, again, just might not look like you or appreciate your story. And so you might not be fully seen in ways that you might need to be.
Can you dive into more of that? Because I know that there's a lot of historical trauma and mistrust around just medical systems in general that can play out here. Can you describe what that role is here?
So I think the historical trauma and mistrust of the medical system is deeply rooted in, our history around racism and discrimination. And if you think about just even the field of gynecology, and I might give a little bit of a history lesson, but, J. Marion Sims is considered the father of gynecology. And at the time, he performed a lot of procedures on enslaved Black women. And that was a very kind of, because of the idea at that time during slavery was that, Black individuals did not feel pain. And so it became these grounds for experimentation, became the basis of this relationship with the medical system that we have to interface with. And there's studies over, just time over time. So you have this person who it was this medical doctor that helped perpetuate this idea of objectification and dehumanization. And that really continued in the research because it led to studies like the Tuskegee experiment that people can look up where, Black individuals, Black males were not given treatment for syphilis to kind of observe how it advanced and to kind of learn more about the disease, but they didn't really tell people what was going on in that. And then also with Henrietta Lacks, who, again, somebody you all can kind of look her up, but for people who don't know, she passed away due to cervical cancer. What they found when they looked at her cells is that there was this regenerative effect that was pretty fascinating, and they actually are still living to this day, but they took her cells without consent. And so there were these interactions with the medical community over the years that just became part of the narrative that Black people weren't allowed to kind of have consent over their bodies. They weren't given full information to have consent or to make these decisions. And when you have that narrative that is being passed down and that you internalize, and knowing that this is how the medical community views you, as objects to be studied and not necessarily to be revered and to be respected, that is something that you kind of carry around with you. And along with, I think, other stereotypes that end up getting, I think, internalized around fertility and loss, or how this happens. I think that's just how that kind of plays out.
Okay, let's talk about progress notes. They can be tedious, time-consuming, and stressful, right? Do you dread writing progress notes after back-to-back sessions? Then try JotPsych. It's basically a practice assistant. It drafts progress notes, coordinates intakes, and manages your schedule, saving you hours every week. And with JotPsych, client data is secure. It's HIPAA compliant, fully customizable, and really easy to use. Notes practically write themselves, and your workflow stress will vanish.
Therapists have already trusted JotPsych with over 800,000 visits. Why don't you give it a try? Visit JotPsych, JotPsych.com/modern therapist and use referral code MODERN for 50% off your first 2 months.
I'm hearing so much about this mistrust and the historical reasons why this has occurred. I know that there's other communities that have experienced that, and even in our conversations, and I'll link to other ones in the show notes about termination for medical reasons, those kinds of things. There's been a lot of mistrust that has been escalating due to policies at the federal level, those types of things. And so to me, it feels like there's a lot that's coming into the room, and there's a lot that would be really overwhelming for clinicians who aren't in this space. And so if you can talk a bit more on how stigma or even disenfranchised grief, I think there's something about the bias that we're, as a society, just putting in place that I'm sure is not allowing for the full experience of the folks that you're talking about coming into the room.
When we think about stigma, we also need to think about maybe the sense of shame and where the stigma is coming from, because I think trying to access resources for reproductive care, I think is challenging, obviously, because of just the biases that, we've talked about, but also the biases are attached to this myth of, fertility and how that's perceived, and this sense of hyperfertility. And I think that's created this sense of insecurity because we live in a pronatalist society, and oftentimes we equate our personhood with being able to become a parent. And when your reproductive story doesn't unfold the way that you expect it to, there's a lot of shame around that, or can be a lot of shame around that. I know there have been narratives around, this myth of hyperfertility for Black individuals and also for other people of color. So it creates this sense of this insecurity of like, why isn't this happening for me? But also there's not this sense of being able to talk freely about it or to seek medical help about it. And when there's been this mistrust of the medical community, you also tend to rely on, when you do reach out for help, you might rely on those within your community, and when you're doing that and they're not necessarily that well informed, or might be also perpetuating misinformation, that becomes a really difficult kind of recipe for, just for more heartache and disenfranchisement. Now, the disenfranchised grief just when we think about grief that doesn't necessarily get acknowledged or losses that don't get acknowledged in general. And I think the infertility experience is a type of disenfranchised grief, in addition to pregnancy losses being part of that grief as well. And so when you're more likely to experience loss that's incurred in a system of isolation and invalidation by those around you, it does, I think, make it more difficult to navigate healthcare, issues and concerns and reaching out when you might need to.
How does that look?
Yeah, I think it looks like not seeking help. There's a delay. Even though Black women are twice as likely to experience infertility, they are 50% less likely to access care. And that's just the data that we have. And we know that infertility exists in the Latino community and the Asian community and the Native American community. We just don't have the robust data to really, kind of do that comparison. So I apologize. I'm talking about this strictly from a Black kind of perspective, but it looks like this delay in care and accessing care, which leads to a delay in diagnosis, which also leads to a delay in treatment. And just what's happening with how even losses might get managed, which unfortunately loss is a sad part of one's reproductive journey. And if someone is experiencing a miscarriage, it might mean that they might not be able to, they might not feel comfortable in reaching out to their doctor, or the doctor might be kind of feeling these constraints of what's happening legally in terms of being able to provide the, appropriate care and intervention, medication intervention or whatever intervention might be determined that's necessary at that point. So it's access to care. It's how one kind of feels.
You talk about weathering.
Yeah.
What do you mean by that? And how does that impact our clients?
So weathering is a very interesting concept because it is basically the cumulative impact of stress on individuals that are living in marginalized communities. And those individuals who are experiencing physical and psychological effects of this prolonged exposure to discrimination from a racial standpoint, from due to their ethnicity or religious or socioeconomic status. However, it can also be applied to somebody who has a kind of a disenfranchised identity along the lines of gender or sexual identity as well. But it's kind of understanding this hardship and how it's been for people to cope under these existing layers of cultural oppression, to put it frankly. And I should also say it's the acknowledgement of what happens to the human body, like right down to the cellular level. So it's this belief that, enduring, prolonged racism, exposure to racism and discrimination actually ages the body.
That's really interesting. I hadn't heard that the aging the body part. It seems like I'm just, as you're talking, I'm overlaying my own infertility experience and thinking about the added piece of the weathering, because I know that there's elements when you are trying to conceive and you're not getting pregnant and everyone around you is having baby showers, and there's that element of weathering to a certain extent that happens there as well. And I think overlaying the additional pieces, it seems like it would be, the word that comes to mind is exhausting, but it seems like it would make it even harder to be able to go through the process and to go through the process with your mental health intact.
Definitely. And, and just kind of reference my own experience. I remember early on in my journey, I remember talking to a colleague of mine. And I think at that point, I'd only experienced one loss. And I just was having trouble getting pregnant again. And I reached out to her and I just said, I remember distinctly how I was dealing with a few different kind of racial microaggressions at the same time that I just found incredibly exhausting. And I was so consumed by that. And I just remember thinking, and I said to her, I was like, I feel like this is impacting my ability to get pregnant again. And she's like, you're not wrong for believing that. But it was so different to the narrative that we'd been taught, or that I'd been taught. So yeah, that there is this experience of this exhaustion and the sense of, how our bodies handle stress and the cumulative effect of stress over time. And so we know that there are, kind of higher rates of kind of heart disease and high blood pressure and other medical diseases within communities of color, and particularly the Black community. Also, premature, just maternal mortality rates are higher. And then, the higher instances of infertility in the community, which is counter to the stereotype that we've been told that, it's actually less prevalent. So, but yeah, it's a very exhausting and confusing kind of experience, but that's a sense of, and I'm glad that we're talking a little bit more about the weathering aspect of health. And as we understand the impact of racism and discrimination on health in general.
Yeah. Yeah. I'm thinking about, with all that's there are realities.
Mhm.
My hope is that we can help at least the clinicians who listen to this show to stop any of their, kind of biases being at least unexamined around some of these things. But the medical system, I've not a lot of hope that
Mhm.
that the
Right.
medical system will change in my lifetime. And I also know that the journey, the fertility, the infertility, and the pregnancy loss journeys are horrible and
Mhm.
oftentimes all consuming. And so I guess I'm asking, how do we support our clients with these realities? Because these things are, they just are.
Mhm.
And so, obviously acknowledging them, letting them know, yes, I see you, this is real. I think that sounds like that was what your colleague was able to say to you, that you're not wrong. Definitely this is a reality. But I think as a clinician, I'd love some more tools to support my clients who are coming in with this these particular challenges.
I think that what that starts to look like for our clients, or sitting with our clients and appreciating, the context, and I like to call it maybe weatherproofing our practice, is, like you said, owning our biases. But when I think about what it means to do that and the power behind that, and bridging that cultural gap, really speaks to what needs to happen within the relationship, and also not just the relationship, but within the therapist ourselves. And so I think there's a lot of the work around honoring biases means not necessarily just developing a sense of cultural competence, but also maybe a sense of cultural humility and also cultural intimacy. Because it's hard to talk, it's hard to connect with communities that we are not a part of. I think it's hard enough to do that in general, but, and we can study them, but there's a difference between studying how to do that and actually doing it. And so I think asking ourselves the question of, how, like, if I'm sitting in the room with somebody, and yes, I'm sitting them in this experience that I don't know a lot about, but in what ways do I kind of honor that disconnect, or kind of thinking about the ways in which, I might have privilege in this area, or how do I use that privilege? And I think the piece that I wanted to make sure to communicate was around weatherproofing, our practice, and leaning into difficult conversations around, or just different moments of, difficult moments of self-reflection, as a therapist, because we are our biggest tool in the room. And, and I know that we give a lot of attention to biases.
Need dynamic, knowledgeable speakers for your next event, training, or conference? Curt Widhelm, that's me, and Katie Vernoy, that's her, bring real world expertise to every presentation, covering topics like supervision, private practice growth, and therapist burnout. Our workshops are interactive, insightful, and packed with actionable strategies to help modern therapists succeed.
Whether you're planning a team training or a large scale event, Curt and I deliver high impact learning experiences tailored to your needs. Book us today. Visit therapyreimagined.com to learn more. I think for me, when I hear biases and specific to our conversation, I think about the biases that come up for me around the stereotypes that you were talking about the hyperfertility, those types of things. I hadn't even really thought consciously about them until you started saying them. I think it's important that as clinicians that we own those things, that we look at them. Obviously, we don't want to do that work with our clients because I think that would be a burden on them. But I think being able to look at where we sit with that and to square off with it, because until we got your proposal to come on the podcast, I hadn't really thought about the differences. I think if I would have thought about it, I would have recognized, of course, there are differences, but I hadn't really gone into the idea of what is this? What does this mean? And so I'm really appreciating this conversation because it's opening up even some smaller pockets of where I need to be paying attention when I have a client who's different from me, who's having a different experience of infertility than I am, to be able to understand that. You also talk about kind of the culturally competent care, that the cultural humility as well as the cultural intimacy. I was really interested about the cultural intimacy and how that could play a role here.
Yeah, I think the cultural intimacy is a pivotal part of developing not just competence or moving from competence to humility, because it's not a fixed kind of process. So we never stop learning how to relate to each other as people. And so I think building trust in relationship, cultural intimacy involves a sense of trust, a sense of closeness. It involves a sense of, really seeing the person, and that might mean, acknowledging these past injustices, but it also means, just kind of engaging in ways that we might not, engage. And when we are aware of our positions of privilege and power and how we've used them, and also maybe thinking about how that intersects with our, ways in which we felt disempowered, it's like that gives us a point of connection, and really searching for what that point of connection is going to look like. But I think that intimacy requires engagement. And how do we continue to stay engaged in communities that we don't fully understand, so that we make sure that our blind spots don't continue to, don't continue to be hurtful or harmful and perpetuating these stereotypes or things that we, just things that might not be helpful.
At least from my experience, my practice doesn't typically start out working with clients like yours. That and what I mean by that is clients that are coming in facing infertility, pregnancy loss kinds of things. That oftentimes where I find that these kinds of issues come up is clients that I'm already seeing run into these newfound issues, and we have this relationship. And I'm wondering if you can speak to clinicians like myself, where it's okay, it's easy to put a conversation like this to the side. I'm never going to see that in my practice until one day you do.
Right. Right.
And on this on this point that you're talking about, as far as having intimacy and not wanting to just put all of this work onto clients, to say, hey, I realize I'm coming at this from a privileged place. I'm coming at this from an outside place. How do you recommend that clinicians in my position end up navigating this as it arises, as it might not be something that we're fully there in our knowledge base, but we do have that intimate relationship with the clients?
What might be helpful, I think what might be helpful, right? Because you're not going to stop seeing a client or a long-term client who all of a sudden might develop some fertility related issues. And then it's like, whoa, sorry, here, let's go see someone else. What that might mean is a little bit more education on the therapist's part, where, you might hear what the client starts to bring up. So if they start to introduce terminology that feels unfamiliar, it might be making a note of that, and then going to do some research and consultation around some of the kind of major terminology that they're kind of going through, or getting a little bit more information about what their specific experience is. So for people who are going through some type of fertility treatment, that might be helpful, just for your own benefits. You have some working knowledge of terminology, so that the client doesn't have to do the teaching of what does an IUI process look like, or, intrauterine insemination process look like. And you have some information about, just going for consultations and procedure, the diagnostic procedures, and then the actual insemination procedures. So there might be a piece around education, and through the American Society for Reproductive Medicine, I know that they have there's actually one free kind of module that can help kind of therapists learn a little bit more about this information.
I think it's also important to make sure that the space is open to be able to talk about things, because even though this is, whether it's pregnancy loss or infertility, it still seems very related to sex and sexuality, and a lot of folks are not as comfortable as clinicians to bring those things up. How have you found is helpful to open a safe space to talk about some of these more challenging topics?
I think what you mentioned about like we didn't get a lot of education, and I don't know about you, but I didn't get any education in my graduate program around reproductive health in general. And so I think, it does make trying to open up these conversations kind of challenging, and wanting to make sure that you have an open and kind of inviting space for clients to talk about this is important. And I think that you demonstrate a level of comfort through practice and acknowledging that you might not get it right. Like you said, like you mentioned very early on in our conversation, it's like we're imperfect beings coming to this. And I think acknowledging to clients that, you are interested, but this might be a little outside your wheelhouse, and you're doing everything that you can to learn, so that they're not put in the position of being the teacher, but that you're still wanting to provide a space for them to feel held. And I think that goes a long way to ensuring clients that, they're not necessarily expecting perfection from us. They really appreciate our humanness. And then I think demonstrating that in a way, I think improves the relationship and that ability to create that space to have a difficult conversation. You're really modeling it for them.
Where can people find out more about you and the work that you're doing and being able to spread more of these ideas?
And so people can find me on my website at drloreejohnson.com. Or I'm also on Instagram at Dr. Loree Johnson, and on LinkedIn at Dr. Loree Johnson.
And we will include links to those in our show notes over at mtsgpodcast.com. Follow us on our social media, join our Facebook group, the Modern Therapist Group, to continue on with these conversations and more. And until next time, I'm Curt Wilhelm with Katie Vernoy and Dr. Loree Johnson.
Therapists, reclaim your evenings and stop getting behind on notes with JotPsych, the scribe assistant made just for you. Try it for free at jotpsych.com/modern therapist. And don't forget to use referral code MODERN to get 50% off your first 2 months.
Want expert training for your team or event? Katie and I offer engaging workshops with real-world strategies for modern therapists. Visit therapyreimagined.com to learn more and book today.
Thank you for listening to the Modern Therapist Survival Guide. Learn more about who we are and what we do at mtsgpodcast.com. You can also join us on Facebook and Twitter. And please don't forget to subscribe so you don't miss any of our episodes.